in anorectal canal, as you know, probably you have learned in preclinical years, there are anal cushions which are located just above our dentate line. These cushions are very important because they serve as sensors within the anal rectal canal, so that we understand what is the content, right, in our rectum, so that okay, probably gas, right, or we know it's solid, right? So we know this, and it's important because for social reasons, we need to know what is inside our rectum, okay? And then these anal cushions also, they play an important role because being cushions, they provide some support to the content in the anal rectal canal, and also they provide some form of continence to the content in the inner canal. So these cushions are made up of arterial venous anastomosis. That means they are full with blood, arterial blood and venous blood. Anatomically, we distinguish hemorrhoids by their position in relation to the dentate line. Whatever that is superior to it, we call it internal, meaning they originate superior to the dentate line. Hemorrhoids that originate inferior to the dentate line, we term them external hemorrhoids. Okay, so internally above, meaning above the dentate line, the epithelium is made up of columnar cells, and inferior to this dentate line, it is made up of enoderm and skin cover. This is important because why? Because columnar epithelium, they don't have much nerve endings. So in a sense, they don't cause much pain, right? As opposed to external hemorrhoids, if they were to be traumatized or we perform surgery below the dentate line, patients will have some quite severe pain because this skin cover actually is similar to our skin anywhere they have nerve endings. So again, I'd like to emphasize hemorrhoidal veins here corresponding with the anal cushions. It is usually located above the dentate line. So this is what we call internal hemorrhoids. If they get engorged, and those below, if they got engorged, those are called external hemorrhoids. So I think it's important to understand the dentate line, and I think it's a very common question in a preclinical exam to differentiate the histology and physiology above the dentate line and below the dentate line. So in hemorrhoidal disease, what happens, what goes wrong is there is breakdown in the connective tissue that supports this hemorrhoidal cushion, this anal cushion. So what happens is all this leads to these blood vessels prolapsing downwards. And once it prolapses downwards, it loses support and it causes more and more rupturing of the supporting connective tissue. It goes on as a vicious cycle. Then it causes disturbance to the defecation process, and the patients tend to strain because they need to increase the pressure to evacuate the feces, and then that will lead to more breakdown in the connective tissue and lead to enlarging of the hemorrhoidal cushions. So in essence, we tell our patient we can distinguish the etiology by patients constantly straining on the toilet, sitting on a toilet bowl or prolonged timing, or it can be pathological in nature. For example, about 30% of hemorrhoidal disease in the elderly, they have a secondary etiology located superior to the hemorrhoids. Or it could be iatrogenic. Sometimes after we have performed surgery in the anorectal canal, for example, cancer surgeries near the rectum, it can disrupt the blood vessels and the connective tissue surrounding the anorectal canal, and it can lead to hemorrhoids forming after our surgery there. So in clinical practice, we classify hemorrhoids, internal hemorrhoids, to 4 grades. Okay, starting from 4th grade, this is the worst, the highest grade, meaning that the hemorrhoidal tissue has dropped down and it can be seen externally, and it is located externally at all times. If it's grade 3, it comes down, it drops out from the anus, but it can still be manually pushed back. So the patients will report that after defecation, they have to use their finger or something and they just push it back inside. Whereas in grade 2, the patients usually will say that they realize something is probably protruding, they can feel it, but it cannot be seen externally. Probably when they strain, might drop out a bit, but it's more of a located internally. Whereas in grade 1, it has no signs externally, but it can only be seen during colonoscopy with small cushions. This is located inside the anorectal canal. And I think it's very important to keep in mind when a patient presents with rectal bleeding from the rectum, or they have some form of pain or mass protruding from the rectum, because not all patients with these complaints have hemorrhoids. It is not uncommon for doctors to misdiagnose cancers or polyps as hemorrhoids. So especially for medical students, you guys will obviously be asked about differential diagnosis when you are presenting cases of patients with rectal bleeding or rectal mass protrusion. Okay, so don't always answer hemorrhoids with me. So what I have done here is I've listed down a few of the more common and relevant differential diagnoses, and I've put them up in this manner. This was taught to me when I was a student like you guys a long time ago. We call this the surgical crescendo. Okay, so it is a way to remember etiology and also to classify differential diagnosis. As you can see, it is given by the mnemonic indicative, right? INDIC. A is autoimmune. In this case, we don't have. T is traumatic. I is iatrogenic. D is vascular. It has an E here. E is for endocrine cause, which I don't think is relevant to hemorrhoids in this case. Okay, so bear in mind when a patient comes to you, or when you see a patient with rectal bleeding or a mass within his or her rectum, anus, so try to think in this way. Could it be infective in nature? Right? Could be warts, could be abscess. So your duty is to ask questions to differentiate, let's say, abscess, right? Could be painful. Patients might have fever, might be pus discharge from around the perineal region. And then if it's fistula in ano, especially the long-term established fistula in ano, patients can always tell you that they have prolonged symptom, right, where they have frequently have intermittent pus discharge with pain and fever. Of course, we are all worried whether patients have cancer or not. So it is our duty as medical personnel to ask carefully whether they have the red flags of cancer, colorectal cancer. All right, red flags like not only rectal bleeding, but symptoms like tenesmus, symptoms like narrowed stool, right, inadequate bowel opening, the sensation of it, okay, and also probably mucoid stool, things like that. So these are more relevant if you're seeing a patient who is more than 40, more than 50 years old, because at that age, then of course the incidence of colon or rectal cancer is much higher compared to a patient who is about 20 or even 30 years old. Degenerative, we have patients, again, probably elderly, especially ladies, multipara. They have given birth a lot of times. there might be some form of obstetric trauma to the perineal region. So the perineal bowl has been weakened. So these patients tend, or they get prolapse rectum easily. Right. So apart from that, you can also entertain whether it could be a perineal Crohn's disease. I know it's less common in our country, in our population here in Malaysia, or even Asian patients. But sometimes you still see patients with Crohn's. Children or younger patients, then you might want to rule out anorectal malformation. Obviously, if you have seen it before, and if you have performed a physical examination, you can easily rule this out. And trauma is very common, okay? Whether it is because of passing hard stools, right, or because of some foreign body is inserted into the rectum. So always keep that in mind. Again, history taking is very important in this sense, and also a physical examination. If you've seen sentinel pile, then you'll understand what is sentinel pile. It looks like just like a skin tight hanging out from the anus. And usually, if there is anal fissure, then the patients usually will be in severe pain. They will not let you examine the anus properly. They will definitely not tolerate a digital examination of the rectum. Again, iatrogenic, usually history itself will tell you patient has a recent history of recent surgery or some instrumentation done within the anorectal canal. And we need to also bear in mind sometimes patients with, for example, liver cirrhosis, they can develop what we call the same varices that form in the esophagus. Sometimes they can form in the anorectal canal as well. So these patients, they tend to have engorged blood vessels. They tend to bleed as well. But the only difference is the etiology is totally different. One, these are caused by liver cirrhosis, leading to portal hypertension. And usually in these instances, the bleeding is much larger in volume. Okay. So by far, the most common symptom of hemorrhoids is bleeding per rectum. And as this picture shows, the blood is usually bright red because it originated just at the end of our GI tract. So the moment it drips out, it is seen red. And frequently, it is not that much, maybe tissue paper or maybe 5 mils, 10 mils at most, right? Unless the patient is on some form of anticoagulant, antiplatelets, then yes, then they will tend to bleed more. But having said that, hemorrhoidal bleeds are rarely life-threatening per se, unless they have this coagulopathy and they are on anticoagulants. Then they will tend to bleed more. And usually, the blood is bright red and it is not painful. Okay. Some patients with hemorrhoids, of course, when they are bigger, stage 3, grade 3 and grade 4, then they present with mass protruding out from their anus. Okay, it could be like this. It could be in this sense. So you can see the difference. This is just the hemorrhoidal cushions prolapsing outwards. So this is probably grade 3 or even 4. This is a bit different. If you pay attention closely here, you can see that it is a bit white or even bluish in color, right? So, and you can see this is, if you go to the government hospitals, this is last time. The inpatients, they wear green gowns, right? So this gentleman is admitted to the hospital, to the ward, because of hemorrhoids. And it is because his hemorrhoids have strangulated, right? It has prolapsed out. And what happens is, in this case, that his anal sphincter has caught on tightly around the hemorrhoids, causing strangulation of the prolapsed part. So when I say strangulation, it means blood cannot enter this part, right? From inside, it cannot come to this area. So that's why it is more pale or even blue in color, as opposed to probably this one. This one probably has some trauma to it, some excoriation, but this guy is admitted because of pain, right? Severe excruciating pain, prolapse hemorrhoid. So again, you can see usually it's pinkish or even purplish, as opposed to this, which is whitish. Okay. Sometimes patients present with some form of thrombosis, meaning bleeding has happened within the hemorrhoids. Excuse me. And then this has caused blood clot to form there. And this again can be very painful. So this is a blood clot forming inside the hemorrhoid. So it's called thrombosed hemorrhoids. Again, we went through the anatomy slide just now. Those were just now, these slides were all about internal hemorrhoids, whereas external hemorrhoids, you can see from this picture, the hemorrhoidal tissue is covered by skin, right? Because it originated from below the dentate line. So it is covered by skin, and being covered by skin, usually they do not bleed as easily as the internal ones. And these are all easily seen by perineal inspection. Okay, another picture showing external hemorrhoids. Okay, but beware if the patient has a history suggestive of hemorrhoids, but there is pain or there is itch, right? And beware if the patient shows you or tells you that he or she is passing mucoid stool, because these are not usual symptoms of hemorrhoids. Okay, so what are we worried of if the patients tell us that they have mucoid stool? Okay, we are most worried about cancer, anorectal cancer. Okay, so this is a patient, again, one of my patients back in Cebu Hospital. This is a lady. She had what was thought to be hemorrhoids. Quite a few years. In fact, she has been to a lot of doctors who just prescribed her hemorrhoidal medications until it got quite severe and painful, and finally got infected, and therefore she came to the hospital. And obviously, even you guys, medical students, can tell this is no more a hemorrhoid. All the while, it was missed as a hemorrhoid, when in fact it is actually an anorectal cancer. So how to confirm hemorrhoids? Usually it's by a physical examination and suspect by history taking physical examination. But the only confirmatory test that we have is colonoscopy. Having said that, we usually reserve colonoscopy for patients over 40 years old. Okay, because after 40 years old, then incidence of colorectal cancer or polyps will start to increase. So that is when that we will offer colonoscopy for patients. And it also forms as an opportunistic screening method to detect colorectal polyp or even cancer. Again, like I told you guys, if the patients tell you red flag symptoms like tenesmus, mucoid stool, sensation of inadequate bowel opening, narrowed stool, or small calibered stool, these are all red flags. Okay, so patients with red flags, you must offer colonoscopy, because we do not want to miss the underlying anorectal cancer. Okay, for those patients who are much younger, maybe 20, early 20s, usually they don't need a colonoscopy during the first instance. Most of the time, these patients can be prescribed with phlebotomic drugs or hemorrhoidal medication. But if they don't seem to improve, again, then you need to have a high index of suspicion. Are we missing out other things, like probably not cancer, right? But maybe inflammatory bowel disease, because inflammatory bowel disease is more common among younger patients, right? So these are pictures from colonoscopy. On the left, put up pictures of cancers, and on the right are pictures of hemorrhoids. So hemorrhoids, they tend to be more well-defined, well-circumscribed. They don't bleed as easily during colonoscopy. You can see these are all bulging like grape-like shape. Whereas cancer, as we know, their growth is haphazard. They are invasive. So they don't have a uniform or similar architecture. They just grow wherever they like. And they tend to bleed easily during scope. Right? So you see this side, there is not much bleeding, even some are quite big. Right? They don't bleed, even though the scope is passing through. Whereas in tumors, whenever you pass through the scope, tends to bleed. Patients, however, will still tell you they have a rectal bleeding, right? Because without doing a colonoscopy, sometimes, most of the time, you cannot detect colon cancer unless you did a digital rectal examination and the tumor is quite distal, distally located. Okay, again and again, I'm showing this picture. Please do not miss anorectal cancer and attribute symptoms to hemorrhoids only. Okay, so clock the patient properly, ask the history properly, examine the patient if possible, perform a digital rectal examination. So we come to the treatment part. This, as we know that hemorrhoids have been described for many years, since I think the times, the ancient times, and a lot of people have tried to treat it because it has been a nasty disease throughout the years. As we can see from historical documents, treatment those days were quite brutal, right? So you can see there's a lot of blood. This is probably the doctor, the surgeon, using some hook-like instrument and a large knife. And the patient doesn't look very happy either, right? Okay, so this is probably a hemorrhoidal procedure being done. A is the unfortunate patient, B is the surgeon, C are probably the nurses, D is probably the anesthetic doctor. Okay, those days, there hardly any anesthesia being given. So you can just imagine how painful this procedure was. Okay, and I kid you not, these are all real instruments being used back in those days. Now they are all only found in museums, surgical museums, but these are all instruments used to perform various surgeries back then. Okay, so nowadays we don't do that anymore, right? For hemorrhoids, as for most surgical or not even non-surgical diseases, most important thing is identify, you diagnose, then you advise for lifestyle changes if possible, right? Before you go to medications, and usually we reserve interventions, or what we call invasive procedures, for the last. Okay, so definitely the easiest to advise the patients, to educate the patient, will be lifestyle changes, right? So avoid constipation, right? It's easy to say avoid constipation, but obviously you need to sit down the patient, you need to go through with them what are their risk factors for constipation, their diet, whether they are doing enough physical activities, whether they are, especially elderly patients, are they taking any or a lot of drugs that might cause constipation as a side effect, right? So all this has to be run through with the patient. Get the patient to reduce weight, again, easier said than done. And then the one habit that is leading to hemorrhoidal diseases will be reading in the toilet, right? Nowadays, you have handphone, so it's probably even worse, right? So there have been studies that show that the incidence of hemorrhoid hemorrhoidal disease increases when the person or the patient spends longer time sitting in the toilet. Right? It is recommended that someone or anybody, do not spend more than 5 minutes. Right? Do not spend more than 5 minutes doing their business in the toilet. Anything more than that, because of the position of the sitting toilet that we commonly use nowadays, where we sit down and our gluteus is open, anal rectal canal is open, there is no support per se. So everything is hanging downward. Everything is hanging downward. So gravity is pulling everything down. So like I showed you just now, when everything drops down, all the suspensory ligaments and the connective tissue are weakened. So over a prolonged period of time, with repeated such positions, then it can lead to hemorrhoidal cushions dropping down, leading to hemorrhoids. Okay, and it is also said that in community or in populations that do not use sitting toilet, okay, do not use this type of toilet, meaning they do their business in a squatting position, it is reported that hemorrhoids are less common in that type of population. Simply because we are created in such a way that our pelvic floor and our glutes all work together in a squatting position, because that is how defecation was meant to happen, in that position, squatting position. So if the person were to squat and to defecate, then that is obviously the most physiological way, and the support for the anal rectal canal, not only the anal rectal canal, but also the other pelvic organs, example, the urinary bladder, and in females, ladies, the uterus and the vagina, the support is optimized in squatting position, right, rather than sitting position. So but nowadays we usually sit. So if we were to sit and defecate, then we advise the patient not to spend too much time, and certainly limit it to less than 5 minutes at a time. Okay. So what about medications? Medications, again, we have simple medications for symptomatic relief. Sometimes hemorrhoids can present with quite severe pain, or they can be quite itchy sometimes. Okay, so symptomatic relief are simple home remedies usually. Things like sitz bath. Sitz bath simply means salt water. So we advise the patient to just squat or sit inside a basin full of salt water for a few minutes. Okay, so that will relieve pain and also itchiness. Of course, we like to give something to our patients. So we usually prescribe some form of analgesic, either topical, apply on the hemorrhoids if it gets prolapsed out, or whether it is a systemic one, usually by oral analgesics. Okay, and of course, because hemorrhoids are brought on because of constipation, so stool softeners also play a role, because when the stools are softer, patients do not need to strain as much when they defecate, and as the soft stool is being passed out, there is less chance of the heart of the stool causing abrasion or trauma to the hemorrhoidal tissue. Phlebotomics, these are medications very commonly given for treatment of hemorrhoids. There are a few types. The two common ones are flavonoids and also calcium dorbacillate. Flavonoids, or the brand name is Teflon. It consists of diosmin and hesperidine molecules. These molecules act on the blood vessels within the hemorrhoidal cushion, right? So they reduce the size of the hemorrhoidal cushion. And this is usually in oral form, tablet form. And now they have made a form that where the patient can apply it directly onto the hemorrhoid in a topical form, right? So it will act on the hemorrhoidal tissue straight away directly. And sometimes people don't believe it, but I always keep a bottle of sugar. This is in the emergency department. This is for patients who present with severe pain, grade 4 prolapse from those hemorrhoids, the strangulated one that I showed you just now. It was white. So how it works is because sugar being it has higher osmolarity. So if you apply it onto a mucosal surface, it will absorb fluid out, right? So if you apply it on a prolapsed hemorrhoid, high sugar, and it will absorb fluid out from the hemorrhoidal cushion, from the hemorrhoidal tissue. So the hemorrhoidal tissue will shrink. Once it shrinks, then it's easier to insert, to reduce it back into the anorectal canal. So I kid you not, this has been published a few years ago, and I really think it works, right? But we still don't have a proper randomized controlled trial to compare sugar with other treatment modalities. But it has been described, the role of sugar. So flavonoids, like I said just now, it works on the level of the venous wall, where it blocks the selectin and the adhesion molecules to reduce inflammatory reaction, and also to shrink down we call it the cell gaps in between, to shrink down the cell gaps so that it will reduce edematous fluid formation, and the whole thing will shrink a few days. Okay, so it is said that for patients who present with hemorrhoidal bleeds, after starting on phlebotomic medication, by one day, half of the patient will stop bleeding, and by second or even third day, nearly all the patient would have stopped bleeding, right? So this graph is to show the numbers of patients who are still bleeding, okay? And this is time. By the third day, it's only 20%. By the fourth day, it's only 8% left, right? This is placebo. Placebo means there's no medication in the tablet that was given. So there is a significant difference. Okay, again, it works because it improves the venous tone by blocking off the inflammatory receptors. So the cell gaps are all get closed off. So there is no more fluid leakage from the venous part. So the whole system gets shrink off. Right? So it is said that it works even from the first hour itself. Okay, so this will lead to shorter and milder attacks. Okay, and also in the long run, if the patients were to take it for a month or two, as opposed to somebody who does not take it, so the person who takes the medication will have lesser episodes of hemorrhoidal attacks. Okay, so again, it is also confirmed to reduce pain. So this is a forest plot. Whatever to the left favors the medication. Okay, and also it improves complaints of discharge or leakage as well. So this drug really works. Okay, having said that, there are also other modalities available to treat hemorrhoids, not only drugs, not only medication. Injection was frequently used previously, and certainly a lot of traditional traditional medicine or alternative medicine practitioners still use it. But in modern surgical setting, we do not use it. We do not perform this anymore. Simply because one, they don't really work, and number two, there is a relatively high risk of complications, mainly infection. And when I'm talking about infection, it is quite severe infection that can cause to perianal abscess, perianal sepsis, and can even lead to destruction of the anorectal region, causing incontinence. Okay, and there have been instances where the injected material forms an embolus. Okay, and it goes all the way up to the lung, right? So it's a form of pulmonary embolism. So it's quite dangerous actually if it's done wrongly. So no, we don't do injections anymore. Okay, rubber band ligation, yes. Usually we do it after colonoscopy or even sometimes in the clinic when the patient is confirmed to have hemorrhoids. But this is only applicable for the smaller size one, grade 1, grade 2. Okay, as you can see, there is an applicator with a rubber band around it. So there's a firing mechanism. So these rubber bands are deployed and they the rubber bands are tied around the hemorrhoids. So what this does is it strangulates the hemorrhoid. So the blood vessels are tied off. The blood cannot flow through anymore. And then after a day or two, this part will necrose off and just drop off together with the feces. And because, like I told you, internal hemorrhoids, they are above the dentate line. So this is not painful, right? Done properly, it is not painful because we are bending above the dentate line. Okay, so even though this is a form of strangulation, it should not be painful. Okay, surgery was and still is the gold standard of treatment of hemorrhoids, usually reserved for patients with grade 3 and grade 4 hemorrhoids because grade 2 usually they respond to medication and also simple rubber band ligation. So surgery is traditionally done by resection, either using a laser diatomy or using scissors, right? So what we do is we resect it, we cut it out, cut out the hemorrhoids. So this will lead to wound formation around the perineal region, around the anus. So obviously, as you can see, this is quite painful. So being painful, so there are also other methods being suggested because obviously people don't like to suffer from pain from the surgery. So the other way described was plication, where sutures are applied to the hemorrhoidal tissue in the hope that it will reduce the blood flow and cause it to shrink. Again, this one does not work because it is not that simple. Blood vessel doesn't just come from here, it comes from everywhere, right? From the top, comes from here directly, comes from the bottom. So plication again does not work. So we don't do it, right? Newer technologies are available nowadays. So we use ultrasound guidance to look for the main hemorrhoidal artery, right? And then we apply a stitch to it. So this will cause the main blood vessel to the hemorrhoids to be ligated off, and hopefully it gets shrink off. Okay. The other method is stapled hemorrhoidopexy. So what this does is there's an instrument that looks like a gun like that is applied into the anorectal canal, and with the help of some sutures that we apply inside. So the device is created in such a way, together with the sutures that the surgeons apply inside. So it will cut off one whole ring, okay? One whole ring of hemorrhoid tissue. So once this is done, you can see that the hemorrhoid tissue is pulled into the device, and the device has a mechanism that just cuts it off in one whole ring. So all the hemorrhoidal tissues are removed in what we call a donut. Okay, a donut. So, but because it is removed in one whole ring, so there is a risk of anal stenosis because the scar tissue forms one whole ring. And if the sutures that the surgeons apply were to be applied too deep, then it can cause anal stenosis. which is about 15%. So this is a disaster. Patient can barely pass motion like this. Okay, so you see the feces is stuck there. This is a disaster for the patient. Okay. So nowadays we try to move away from that as well. So we do something even more advanced, some will say. So we use laser. Okay, so laser as this probe. This is a laser probe. So during surgery, we insert it. Okay, we insert it into the hemorrhoidal tissue and we apply the laser. So it forms, it heats up, and then it coagulates the blood vessels inside the hemorrhoid. So we call it ablation, but we don't only use laser. There's also some other form of technology using infrared, radio frequency as well. And these are all heat. And I know some surgeons in Italy, they use cold, okay, cryo cold to sort of freeze off the hemorrhoids and let it drop off by itself later on. Okay, so this is how the laser works. A simple diagram, a very simple diagram, just to show. Poke in the needle and then you burn it off. Okay. After being burnt off, being coagulated, then it forms a coagulum or some form of scar tissue that is much smaller, and after a while it will just drop off by itself. Okay, so this is laser hemorrhoidoplasty. So this is a probe being inserted and the laser being activated. Okay, so these are just some pictures of hemorrhoids. Okay, so we have done colonoscopy. We made sure that these are not cancers, and this patient has undergone laser hemorrhoidoplasty. So this is a grade 4. So good outcome at the end of the surgery. Again, another one. This one has got a lot of external component here. You can see these are all skin, right? But it's all bulging in a circumferential manner. And this is the internal component picking out. So again, grade 3, grade 4, but with a lot of external component, right? So post laser procedure, all shrunk up. Okay, so recap. So this slide is just to show that treatment for hemorrhoids is basically guided by the grade, right? So the lower the grade, you can use medication, you can use everything to treat actually, but we don't really do it lah. So the grade 2 ones, yes. Okay. Grade 3 again, some of these more demanding ones we reserve for grade 3 and grade 4. But for medical students, I think you probably don't really need to. You probably need to understand this, but you won't be really tested on this slide lah. Okay, so I think more importantly is in terms of hemorrhoids, you need to understand the anatomy and of course the physiology of defecation. If you're still in preclinical setting, you must understand that, and then you need to understand why our lifestyle causes problems and dysfunction to the defecation, the physiology of defecation, and leading to all sorts of anorectal diseases, not only hemorrhoids now. Okay, and then you must understand that hemorrhoids, although bleeding is the most common symptom, they do present in other ways, especially the bigger ones. They might prolapse out. Patient might come to you as a mass protruding per rectum. Infrequently pain, only if it's infected or thrombosed or strangulated, right? Always remember your differential diagnosis. Nothing beats a good history taking and physical examination. Just by doing these two, you will definitely differentiate and find a diagnosis. You can differentiate your diagnosis in most of your patients, maybe 80 to 90% of your patients. And certainly that, for medical students, that will be the basis or the main thing that we more senior doctors want to test you on. Okay, we won't be asking you so much about treatments, what type of treatments and things like that. Unless you are a good student, you have clearly shown that you have passed the basic stuff, then yes, we'll ask you those type of questions. What we are more interested is whether you can get a good history, perform physical examination, whether you can tell us that even though you have patients with hemorrhoids, you are also thinking of other diseases and you are actively looking for ways to confirm the hemorrhoids and to exclude other diseases. Okay, so that is more important. So of course, so proper medical evaluation is very important. It starts from being medical student itself. And for those in the clinical setting already, or even those who are housemen or MOs, you need to understand that there are multiple treatment modalities available for hemorrhoids. Okay, thank you.
Thank you, Doctor, for your, we can say, is enlightening presentations. And now we open the floor for questions. Please feel free to ask doctors about hemorrhoidal disease or any related topic. You can type your questions in the chat box and I can help you to read a question. One of the students say, how much is the total cost for the, I think it's treatment?
Total cost. Okay. Cost. Okay. We start from below lah. So below obviously more expensive, thousands of ringgit. Laser will be almost 10,000. This ablative techniques. Rubber band is very cheap. It's really a simple rubber band only, and you just need a suction applicator. Just put it in. We are talking about a few hundred ringgit. Sclerotherapy, the injection ones, it depends on what is injected, but nowadays we don't do that anymore. Medication, the original one, Deflon, is more expensive. Maybe a month it costs about 200-300 ringgit. But in the government hospital, they have what we call generic drugs. Generic drugs mean these are flavonoid drugs as well, but they are not made by the original company. Another company produced it, and I think they signed contract with Ministry of Health. Obviously, Ministry will get a cheaper price. So in terms of that, then medication will be the cheapest, I would say. And of course, nothing beats the others, the lifestyle modification. That is, of course, free of charge, but that is also the most difficult one because patients, it's not easy to modify your lifestyle. Okay.
Okay, thank you, doctor. I hope doctors answer your questions, Ross. Okay, we can see the second question here. Can it happens even to the babies?
Babies, okay, babies, no. Simply because the pathophysiology is such that the connective tissue around the anal rectal canal along the anal cushion has to be damaged before they can prolapse out and cause it to swell up. So babies being babies, one, they are not standing yet. Number two, usually their poop is softer, especially those that they are softer, and usually no lah. If we have babies with rectal bleeding or mass protruding per rectum, it is more commonly to be some form of infection. Okay, maybe because the diapers wouldn't change or what, might bleed a bit. So the parent might say, oh, bleeding. Or it can be abscess, or it can be something else like babies. Usually infection or some form of bleeding only just some usually abrasion at the skin or outside the region there. Unless it is some form of congenital problem, then that is different So if they have anorectal malformation, the milder one not the what you call anal there is atresia, anal atresia, things like that. No lah. Maybe the milder one, the anus and the vagina or the vulva, they join together. So that one, yes, they might present with rectal bleed. Right? But hemorrhoids per se for babies, no. Even young people, teenagers, maybe yes, maybe yes. But most of the patients are actually at least 30 and above. 30 and above. Okay, I hope that
Thank you, doctor.
answers your
And then,
questions.
okay, next question is this disease congenital and can it cause fatal?
Sorry, can cause what?
Fatal death.
Death. Oh, okay. This is not congenital, but whether it is fatal or not, it depends on what complications set in, right? Obviously, per se, hemorrhoids don't cause death, but if they were to bleed a lot, and especially if the patients have underlying heart disease or multiple other diseases, and they are on things like warfarin, anticoagulants, antiplatelets, then they bleed too much, then obviously that might lead to something else like heart attacks, symptomatic anemia, things like that. Sometimes we have patients with complications post procedures. Like I told you just now, the injection one is very dangerous. That one can cause infection, and infection can lead to perennial sepsis. That is life-threatening. Okay. And having said that, sometimes, especially procedures like the laser one as well, patients might bleed post-op, even though it's not common. But sometimes the bleeding post-op can be worse than the bleeding from the hemorrhoid itself. So that one, if the bleeding is severe, then it might be life-threatening as well. So directly, I think it is not, I wouldn't say it is life-threatening, but indirectly, I think it might lead to another thing happening, and that thing might be life-threatening.
Doctor, can I ask a question? In hemorrhoidal patients, should they stop taking any anticoagulant drugs?
No, 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 no. If the hemorrhoids are not bleeding, by all means, don't stop. Right? Because I'm sure the anticoagulants, antiplatelets are prescribed for a reason, right? Be it most probably cardioprotective or primary or secondary prevention, or even sometimes tertiary prevention. So if the cardiologist or the physician thinks that the patient needs to be on antiplatelets, then by all means, go ahead. But if there is bleeding happening, and especially if the bleeding is a lot, then it will come to a time that the doctors will have to sit down and discuss among themselves and also with the patient whether it is better to intervene and sort out the hemorrhoids before resuming the treatment for antiplatelets and anticoagulation. Okay, so that is in broad. I'm giving in broad words only lah. That one, most of the time, treatment is more of individualized treatment. So it depends on a patient-to-patient basis.
Okay, thank you, doctors. Next question is is that possible for the patients to experience recurrent hemorrhoid even after they complete the appropriate treatments?
Okay, so hemorrhoids, if it has been properly dealt with, then the chances of recurrence is probably not high, probably at most 15% if you were to wait long enough. Okay, there were studies who followed up patients after the hemorrhoidectomy, the one that cut away one, because that is the traditional way. That is still the gold standard how to treat hemorrhoids. You just resect the hemorrhoid away. So for these patients, if you were to follow them up post-op until 15, 20 years later, it is found out that about 10 to 15% of them will have recurrence, even though it was most probably done properly. I think this is more to do with the lifestyle of the patient, where patients are prone to constipation, or some patients, without them knowing, they have some degree of obstructed defecation syndrome. I don't know whether I should tell you all this because these are all high-end anorectal diseases. So what happens is they feel that they are passing motion quite smoothly, but since young, their mechanism, the pelvic floor mechanism, the anorectal mechanism has been dysregulated. So, like I told you, the physiology for them is not really in tune. So what happens is their anorectal canal pressure is higher, especially when they pass motion. But for them, they feel it is normal because that is for them, it is normal. It is how they pass motion since young. So these type of patients, they without them knowing, their pressure is higher. So obviously they will have all sorts of problems and disease associated with defecation problem. So most commonly is hemorrhoids, and these patients, even though they have gone through proper hemorrhoidal treatment and surgery, the risk of recurrence is relatively high. Not at the area that has been resected, but probably at new areas. So yeah, there is a risk of recurrence. So traditionally, we quote it at 15%. 15% if you follow up the patient long enough, 10 to 15 years. So for me personally, I tell patients, 15 years from now, you have a 15% chance of recurrence.
Okay, so there's still the possibility for the patients to experience recurrent hemorrhoid. The
Yes.
next question is from Ikwan. He say he want to ask regarding type of foods. Do food causes the disease? Because according to what he say, all people say spicy food can cause us hemorrhoidal disease.
Yes. Spicy food, yes, by anecdotal evidence and advice from our elderly people. Probably because spicy food contains some certain chemical, capsaicin, that causes blood vessel engorgement. All right. So that is why when we eat, we feel hot, spicy in our mouth, tongue, lips, because the blood vessels all got swollen. Blood vessels all open up, right? So much so that some people you can see that there is a bit of edema. So I think what happens there in the lip, in the mouth, if the chemical property is not properly cleared off, it can still pass out within the feces, and then obviously it can cause something like that to happen to the hemorrhoidal tissue. So I'm not aware of any proper studies this, but probably you guys should go and find out and read up and see how what are the evidence of spicy food. But that is a good one because a lot of people have been saying that. Obviously, our elderlies are also saying that. So maybe should form a basis to do a study for one of y'all.
Yeah, perhaps in the future we can do this. And next question is from Haris. He asks, usually how long for the patients to regain normal bowel function and feel comfortable during defecation after the surgery?
Oh, okay. Depends on what type of surgery. If let's say the traditional hemorrhoidectomy where you cut away, so there is wound there. So usually that wound will take at least 2 weeks to a month to heal. Okay, 2 weeks to a month. So the first few days will be quite painful, simply because the external component is also cut off. So you can see the skin is also cut off. So the first few days will be quite painful. After a week, then usually the pain will be much better tolerated, especially they will be given, patients will be given a lot of analgesics. So because of that, because of the pain being such a major component of hemorrhoidectomy, so even though that is still the gold standard, now we are looking for less painful ways to deal with hemorrhoids. Okay, so that's why you can see I put there Doppler guided stapler, okay, ablative techniques using all sorts of technology. Simply because people want to find a way to treat hemorrhoids without the pain. But having said that, most of these, what we call modern techniques, are still relatively new, right? At most, they are 15 years or 20 years being performed for the past 15, 20 years. So for surgical techniques, 15, 20 years is still considered new, right? Because compared to open, which has been performed for hundreds of years, it has been proven for so long that it works. It treats 85% of the patients up to 15 years. It's just that the pain is the problem. So the newer techniques, the pain is less of a problem, or that's what the people who sell the machine claims to. So again, it also depends on the person doing it. Obviously, if a person who doesn't know how to use the laser uses it wrongly, also it will cause damage and cause pain. But if being done properly, then yes, the pain is much, much, much lesser, right? Especially for things like stapler, because stapling, as you know, the donut that is being cut off is above the dentate line. So whatever is above the dentate line is not pain sensitive, pain insensitive. So there's not much pain, right? So even for lasers and all that, you're supposed to do it above the dentate line. So that's why there's not much pain there. So, but however, having said that, these techniques we need to bear in mind. They're still quite new. We still need to monitor what is their efficacy over the years. So we can only answer this question about efficacy probably another 5 to 10 years time. When you guys become the surgeon, then you will probably know how efficacious is laser compared to open technique, because you need time to observe the problems that can come out later on.
Okay. The next question is, can other gastrointestinal disease such as IB, inflammatory bowel disease, predispose a persons to develop hemorrhoidal disease?
Not directly, not directly. Probably indirectly, because simply because hemorrhoids forms so commonly. Probably a lot of us also might have to a certain degree, but it is more of connective tissue breaking down around the anal cushion. So that is the main pathophysiology, what we call the sliding theory. Everything slides down, right? So, but let's say inflammatory bowel disease or cystic fibrosis or any GI problems, medical problems per se, they do not cause this unless maybe patient has connective tissue disease, right? Then that's different, connective tissue disease, then that affects the whole body, not only hemorrhoids. So maybe not directly. So, but having said that, it is more of a differential diagnosis. Things like inflammatory bowel disease, if you were to tell somebody with IBD, you tell after you have hemorrhoids, then you start patient on hemorrhoidal treatment, then obviously he won't heal. He will probably get worse. So it is not a known direct cause, but obviously things are not that straightforward in the real life. Maybe they have gone to somebody and got some form of treatment, or something, some form of complication happened because of the probably Crohn's disease that caused some form of hematoma or infection, scarring within the anorectal canal that might predispose to hemorrhoids to form. Right, so it's an indirect or causative manner rather than direct. Understand? Crohn's is more commonly to present as fistula infection because there is inflammation going on. So there is inflammation and contamination by bacteria. So in the perineal region, Crohn's, they present similar with a fistula or abscess rather than hemorrhoid. But maybe Crohn's can cause some form of bleeding or hematoma that is mistaken for a hemorrhoid, but they do not cause hemorrhoids per se. Okay. Hello.
Seems like our moderator has lost the connection. Great.
Oh, okay.
Okay. So maybe last question, doctor. Okay.
Mm-mm.
Can pregnant women get hemorrhoids?
Oh, yes. Pregnancy is one of the physiological risk factor lah. As you know, the gravid uterus, especially in the second or third trimester, getting bigger and bigger. When the baby descends in preparation for delivery, it presses on the pelvic floor, pelvic vein. So all that will lead to hemorrhoids forming. So it is quite common. Okay, quite common. I think up to 70-80% of pregnant ladies will have hemorrhoids. But usually we try not to intervene if they are pregnant, because we know once the baby is delivered, then everything will improve and hopefully go back to normal. All right. So we try not to intervene, and simply because also intervention has its risk. We know that it is not life-threatening. We know that it might improve. Most probably it will improve later on. And if there's not much of a big problem, usually we don't intervene for pregnant ladies with hemorrhoids. Unless it is very bad lah. Things like thrombose or prolapse, or patients bleeding a lot until become anemic, needing blood transfusion, or then that's a different story. Then the surgeon will need to discuss with the lady and the family members and also the obstetrician. So that again is a case by case basis. But in general, for you guys, it's just enough you say it is most probably a reversible one. Usually we will not treat. At most, if it is bleeding a lot, then we'll offer the simpler treatment. Right? I get that chart given there. You say you offer the simpler treatments because you do not want to bring unnecessarily high risk to the mother and baby. So simpler treatment meaning banding, lifestyle modification, things like that. Okay, any more?
Any more questions?
Oh, you're back.
Yeah, sorry. My Wi-Fi
Never mind.
off. If you have any question, you can retype in the chat box because I can't read the previous question anymore. Okay. From what I okay, no more question. And then okay. As we conclude today's forums, once again, I would like to extend our gratitude to Dr. Chea for sharing his valuable insight and also experience with us. Your dedication to both practice and also educate the next generations of surgeon is truly inspiring. And before we wrap up, we would like to take a group photos to commemorate this event. We will kindly ask all the participants to turn on your camera for the photo sections.
Doctor, maybe you can stop sharing first. Is that okay?
Oh, okay.
All right. And all the participants can turn on your camera. All right. Nice.
Yeah, stop it, right?
Okay.
Yep.
Ready, everyone? Open up your camera. Maybe.
Okay.
All right. Ready? Few more seconds. No more? All right. Okay. So ready? Smile. 1, 2, 3. Wait, yeah. One more take. Okay. Keep smiling. Okay. 1, 2, 3. 1. Last one. 1, 2, 3. 1, 2, 3. Okay, that's it.
Okay, thank you to everyone who attends and participates. Before you left this online forums, we will kindly ask the participants to scan the QR for evaluations. Haris, maybe you can present the QR. Yes, this is a QR. Please scan it and give us some feedback on our forums today. Lastly, we hope that you found these sections very informative and at the same time you feel motivated. Let us continue to strive for excellence in our medical practice and also in education. Good night and have a good rest. Thank you, everyone.
Thank you, Dr. Chea,
Okay,
Bye,
for
okay.
doctor.
your time.
Okay,
Thank you.
Okay, good night.
Thank you,
Bye-bye.
doctor.
Thank you, doctor.
Okay, bye.
Thank you, doctor.
Thank you, everyone.
Thank you, doctor. Thank you, everyone.
And for those participants who haven't scanned the QR code, I will leave it here to give you some time to answer the feedback.
Thank you, UNIMAS.
Welcome.
Thank you, Jinswan. Thank you, Edson.